Differential diagnosis of generalized lymphadenopathy. Lymphoma. Any age. Usually cervical group is involved first. SVC, obstruction. Fever, night sweats, loss of weight. Hepatosplenomegaly. Pleural effusion, often bilateral, or ascites. Discrete, rubbery, or firm, non-tender lymphadenopathy. Acute lymphoblastic, leukemia, all. Children or young adults. Fever may be very high. Discrete, non-tender adenopathy. Moderate splenomegaly with hepatomegaly, severe anemia. Very short course of disease. Hemorrhagy manifestations, purpura, gum bleeding, epistaxis, mouth ulcers, sore throat. Presence of sternal tenderness. Chronic lymphocytic leukemia, CLL. Over the age of 45 years, peak 65 years, and M greater than F, insidious onset. Firm, discrete, painless, generalized lymphadenopathy. Moderate splenomegaly with hepatomegaly. Gradual onset of weakness, slowly developing pallor and presence of irregular fever. Hemorrhagy manifestations into the skin in late stages. Increased frequency of infections. Absence of sternal tenderness. Disseminated or miliar white tuberculosis. Children or young adults. High rise of temperature with drenching sweats, loss of weight, progressive anemia, cough, and rarely breathlessness. Glands are palpably, matted, means peritonitis, usually painless, but may be painful, firm, without any rise of local temperature, rarely there may be a sinus present in the skin with formation of cold abscess underneath. Hard and craggy nodes are found in healed and calcified tuberculosis. Upper deep cervical group of nodes are commonly affected. Paucity of signs in the chest, miliary. Often few crepitations are heard late in the disease. Mild hepatomegaly with mild, tender splenomegaly. Choroidal tubercles may be seen, 25%, in the retina by ophthalmoscopy, miliary. Mantoux test may be negative, miliary mottlings may be seen in chest x-ray, and chyoidine granuloma in lymph node biopsy may be found. Choroidal tubercles are yellowish and slightly shiny lesion. Secondary metastasis in the lymph nodes. Middle or old age commonly. Lymph nodes are stony hard or craggy, fixed, non-tender, generally localized, rarely generalized. H/O hemoptysis, melena, sore throat, breast lump etc., anemia with emaciation, cachexia. Presence of primary source like carcinoma of head, neck, thyroid, lung, breast, or stomach. Though initially non-tender, pain and tenderness of variable intensity may appear lately. Secondary syphilis. Usually in young adults. Past H/O exposure and primary syphilis, example genital ulcers. Moderately enlarged, discrete, firm and shoddy, painless and non-tender adenopathy. Though the distribution is generalized, there is predilection for affection of occipital and epitrochlear nodes. Skin rash, condyloma dilata, and snail track ulcers, mucus patches, in mouth may be seen. NB, secondary syphilis is not commonly seen nowadays because of the early use of antibiotics in the treatment of chancre. There may be hepatosplenomegaly. Infectious mononucleosis. Children or young adults. Adenitis is mostly cervical, posterior cervical group, may be generalized. Glands are palpable, a bit tender, with moderate enlargement. Fever of short duration, malaise, headache, sore throat may be present. Acute onset with a maculopapular rash, like drug rash. Petechial hemorrhages may be seen at the junction of the hard and soft palate. Spleen is often palpable. Atypical lymphocytes in peripheral blood. Positive pulmonale and in monospot tests. Systemic lupus erythematosus, SLE. Young or middle-aged female patients. Present with arthralgia, arthritis, pijo, myalgia, butterfly rash in face, oral ulcers, or oliguria. Moderate splenomegaly with hepatomegaly. Non-tender, discrete adenopathy. Pleurisy, pleural effusion, pericarditis, or renal failure may develop. Sarcoidosis. Usually in children or young adults. Generalized adenopathy with frequent involvement of pre- and post-auricular, submandibular, epitrochlear, and paratracheal nodes. Mild splenomegaly. Classical skin lesions, lupus pernio, uveitis, or parotid swelling may be seen. Patient may have cough, dyspnea, fatigue, or presence of erythema nodosum. Bilateral hilar adenopathy in chest x-ray, positive FAME test, elevated serum angiotensin converting enzyme, SACE, and negative Mantoux test are characteristic features. Filaria's 1S. Any age. Fever with chill and rigor initially with every full moon and new moon. There may be pain felt in the scrotum, breast, vulva, or erythematous and painful cord-like swelling in the limbs. Spermatic cord may be thick and tender. Non-pitting edema of legs with pod-orange appearance of the skin may be seen. In the chronic stage elephantiasis, lymphedema as well as increased thickness of skin, of scrotum, vulva, or legs with pleural effusion, chylus, ascites, chylus, and chyluria may develop. Discrete, non-tender palpable lymph nodes in the inguinal region may be generalized. Pod-orange appearance and lymphedema are often associated with filariasis and malignancy. Chronic lymphadenitis. Common in cervical and inguinal lymph nodes. Primary focus is usually present in the oral cavity, scalp, genitalia, or in the neighborhood of the affected glands. Moderately enlarged, firm, mild tender, rarely matted. There may be rise of body temperature. HIV infection, AIDS. Any age, young adults, commonly. H/O homosexuality, promiscuous sex, or receiving blood transfusion. Patient may present with infectious mononucleosis-like illness with pyrexia, rash, and lymphadenopathy. A subgroup of patients with asymptomatic infection may present with persistent generalized lymphadenopathy, PGL, or AIDS-related complex, ARC. Patient with ARC may have chronic diarrhea, night sweats, fever, weight loss, and oral candidosis. PGL is defined as the presence of enlarged lymph nodes, LCM, in 2 or more extrainguinal non-contiguous sites for more than 3 months. Lymphadenopathy in AIDS may be due to diseases like tuberculosis or lymphoma. Rapid downhill course. Biopsy of the lymph nodes show reactive hyperplasia. ELISA test for HIV antibody, screening test, and Western blot test to identify antibodies to specific viral protein, confirmatory test, are positive. Amyloidosis. Drug-induced.